We have an excellent speaker and we'll talk about one of the commonest emergencies in gastroenterology. So I would request Dr. Mandani sir, Dr. K.K. Singh to please introduce our speaker.
Good afternoon, everybody. Let me take this opportunity to introduce to you Professor Pramod Garg. He is the head of the Department of Gastroenterology at All India Institute of Medical Sciences, New Delhi. Professor Garg needs no introduction. He is a world-renowned figure in the field of pancreas, and he has made landmark contribution in the subject of chronic pancreatitis and acute pancreatitis. So now he has taken over as the HOD of the Department of Gastroenterology, which has been consistently ranked #1 in various surveys, and I have no doubt that sir will take it to its pinnacle in a few years. I have the opportunity to work under him while I was doing my DM, and it is not only gastroenterology that I have learned from him, but it is there are a number of invaluable life lessons which I have learned, be it in dedication, be it in honesty, be it in patient care, be it in critical thinking and decision making. He was a very tough taskmaster, though he has, but I decided to take the fire front on, and I decided to directly work under him, and I've learned a lot from him. So I may not be his best student, but he was my best teacher, and thanks a lot for this, sir. Your podium is now, sir, yours.
Distinguished guests, office bearers, Madam Tripathi, it is indeed my honor to deliver this Dr. Anup Tripathi oration, and real pleasure to be in Allahabad, where I have the opportunity of meeting many of my friends, Rohit, my batchmate Geeta, and her smart husband Dr. Tripathi I just met, and many others. First of all, I would also join you in, no, I don't think this is my slide. Is that correct? Yeah, this is one. So first of all, I join you in paying my tributes to Dr. Tripathi, whom we have just heard was a brilliant pathologist and a fine human being. I think we should all emulate in our lives to do not only good work, but also be good human beings to help others. And our profession actually gives us that opportunity every day, every minute to do that. So my heartfelt tribute to him. Now I'm going to talk about approach to a patient with pancreatitis, which usually begins with acute pancreatitis, and those patients who have severe disease. Many of you are surgeons here, I know. If you open the abdomen and you see a picture like that, even the most daring of surgeons will be scared of going in and doing anything. So it is really an abdominal emergency, at least in the beginning. Surgeons are also not, willing to do anything in this patient, and rightly so. It is associated with high morbidity and mortality. And mortality actually in severe cases may be as high as 40%. I'm going to talk about a little bit about diagnosis, severity, management, role of internist, role of surgeon, and some special situations, because I am told that in this August Hall, there are many pediatricians and gynecologists and surgeons and physicians. So I've geared my talk to those who might see the patient firsthand when he comes with acute pancreatitis. It's one of the commonest disease that we see, but I think in general practice also, among patients who present with acute abdominal pain, you would find many having acute pancreatitis. The incidence has been found to be between 30 and 80 per 100,000 population, and perhaps increasing over a period of time because of two reasons. One, that the gallstone incidence is also increasing and alcohol consumption is increasing, which are the two common causes. And this is one of the commonest indications for hospitalization among patients who are admitted in GI services. And typically a patient comes to you with acute abdominal pain, and if you find the raised amylase or lipase more than 3 times, you can safely make the diagnosis. So you need 2 out of the 3 criteria. You don't need to do any imaging. The point I'm making here is you don't need imaging to diagnose acute pancreatitis. Amylase or lipase, either of the two, is considered one of the very good biomarkers to diagnose the disease. It is not 100% specific or sensitive, but in most patients you are okay in making the diagnosis based on these two. But one of the important things about amylase or lipase is that if there is increased triglyceride, if patient is alcoholic, or there is underlying chronic, then the levels may not be raised to that level. And second, if you do it after 3 days or so, then the levels usually come down. The other thing important is there is no correlation with the etiology or severity of the disease, and there is no need for you to monitor serum amylase or lipase levels. The reason I'm emphasizing that, we often see patient having amylase done every 2nd or 3rd day or 4th day. It has no meaning. And as I said, commonest cause remains gallbladder stones. The second important cause is alcohol, and there are other causes. About 20% we don't know what's the cause. So acute pancreatitis associated with both local and systemic complications. And in the systemic complication, the first thing you can notice is systemic inflammatory response syndrome, wherein patient has tachypnea, tachycardia, raised counts. And in organ failure, in the beginning itself, within the first 2-3 days, some of the patient might develop organ dysfunction away from the pancreas. The key here is you have a local inflammation in the pancreas, but distant organs, lungs, kidneys, and heart get affected in those with severe disease. And that's a problem. And local injury could be inflammation or necrosis. For example, here you see almost a normal looking pancreas with little bit of fluid collection here and inflammation. This is mildest form of pancreatitis. In some patients you find there is a lot of necrosis. Here almost the entire pancreas is necrosed. In some patients you have pancreatic necrosis, but also you have peripancreatic necrosis and fluid collections. This is a rather severe form of disease. Later during the course of disease, you may have seen many patients who develop large fluid collection, often called as pseudocysts. And nowadays we make some distinction here that if in that collection you find solid necrotic debris, we call it ward of necrosis. The reason to differentiate between the two is when you drain here, you have to take out the necrotic debris, and these patients are more prone to develop secondary infection. I have told you about diagnosis. One of the things that you often encounter, because I have shown you just the CT pictures, every patient has a CT done in the beginning and then repeated CTs. This is not to be done. First of all, they don't require CT in the beginning of the disease. Only when the diagnosis is in doubt, you should do a CT scan, otherwise no. After 4 to 7 days, sometime you may need to do it for prognostication, but not in all patients, by the way. And subsequently, CT is required when you have to do some interventions for complications. So my job here is to focus on management in the first 2 weeks or so. So as I said, it can be associated with local injury and systemic inflammation, and local injury leads to systemic inflammation. Local injury could be just inflammation or pancreatic necrosis, and systemic inflammation presents later as organ failure, commonly affecting the lungs, and some of these patients end up in ICU. So most patients with severe pancreatitis with organ dysfunction should be managed in an ICU. So many people have divided these, the acute pancreatitis into different categories. The simplest to remember is mild disease, no major local or systemic complication. Moderate disease when you have local complications like necrosis or fluid collections, and severe when you have organ failure, distant, away from the pancreas. And this usually present in the beginning as systemic inflammatory response syndrome. And if you want to learn a little bit more about that, one of the papers we published many years ago, you can refer to that, where we have shown how necrosis correlates with organ failure. Now coming to the management in the first 72 hours, I'll give you a clinical scenario. Most of you would come across such patients. Whatever your practice is, you will see patients with abdominal pain. So this lady came in with abdominal pain for a day. Pain was severe, associated with vomitings. Amylase was very high, and you can safely make the diagnosis here. X-ray abdomen was normal. Now, I want to emphasize this for those of you who are younger, that often X-ray abdomen is not done, but this is very important to rule out perforation, peritonitis, and intestinal obstruction, which are more common as the cause of acute abdominal pain than pancreatitis. So please do X-ray of the abdomen in these patients. Ultrasound was done. We showed a bulky pancreas, small fluid collections with gallstones. So we likely dealing with gallstone pancreatitis. And the reason I say likely, not definitely, is that we have to have an abnormal LFT here. Bilirubin was 1.8 here, SGPT was 260. Now, if you have gallstones with abnormal LFT, you can say it is gallstone pancreatitis. But if your LFT is normal, we don't know it is because of gallstones. It could be because of any other etiology. That's the point you should remember. And this LFT should be done in the beginning, within the first 24 hours or so. And CT, of course, is not required here. So what are your concerns here? Patient has come in on day 1. Should I refer to a higher center? What analgesis should I give? Patient is having pain nil by mouth. What fluids? How much? Do I need to do ERCP? Do I need to do CT now or later? Does the patient require antibiotics? And how about nutrition? These are the things that you should consider in the first few days. There are many prognostic scores, either single markers or multiple markers. 2 things if you remember. 1, patient having systemic inflammatory response syndrome, which is clinically diagnosed, and or organ dysfunction. Please refer this patient to a center where better facilities are available, particularly ICU facilities. Best thing is to this, remember is this. Coming to analgesics, because the first problem patient has is pain, and you have to control the pain adequately. You have 2 choices, either give NSAIDs like diclofenac or give opioids, whether tramadol or pentazocine or some other opioids. The concern is there with either of these 2 because they may be associated with certain adverse events, both NSAIDs and opioids like renal failure, GI bleeding, ileus. So not much data is available which is a better analgesics. We did a randomized trial comparing diclofenac and pentazocine, which is an opioid. We thought NSAIDs would be better because it has both anti-inflammatory and analgesic properties. But what we found was that pentazocine opioid was better than diclofenac, and a couple of other studies have also shown that opioids are better than NSAIDs in providing pain relief. So my recommendation here is that you should give opioids, but you can supplement it with NSAIDs if required in some patients. The next problem is that patients having pain, not able to take anything by mouth, and we have to give fluids. So one of the problems which occurs in many patients with acute pancreatitis is that they lose some fluid in the interstitial compartment because of increased vascular permeability, and also there is a lot of fluid coming around the pancreas because of inflammation. So they are kind of dehydrated. Now, initially people thought that they lose a lot of fluids. The fluid deficit is quite high. In fact, earlier study showed it could be as high as 5 to 6 liters. But more recently, we understand that the fluid loss or fluid deficit is around 3 to 3.5 liters. And that is why the issue came in how much fluid to give. So many people advocated aggressive fluids, 5-6 liters a day. But 2 years ago, we had this very important trial published in NEJM comparing aggressive versus moderate fluid. And moderate fluid here was 1.5 ml per kg per hour, and a bolus only if there is hypovolemia or hypotension. In the aggressive arm, they gave 3 ml per kg per hour. That means around 5 liters a day. And here it is around 3 liters, 2.5 to 3 liters a day, depending on the weight of the patient. And what the study showed, that there was no difference between the moderate and the aggressive or non-aggressive arm in terms of incidence of moderate to severe pancreatitis. The primary outcome was similar, but in the aggressive fluid arm, they found a lot more patients developing fluid overload. In fact, the trial was stopped after recruiting about 250 patients, and the recommendations thereafter have been that you should give moderate fluid, non-aggressive fluids. One of the things I would like all of you to remember is when you give intravenous fluids, it doesn't stay in the intravascular compartment for long. And if you give 1 liter of renal lactate, any fluid, the plasma volume expansion is not more than 250 ml. 750 has gone out of the body, of the compartment. And within a few, rather 1 hour or so. So when you give too much of fluid, by the way, to any patient, forget about pancreatitis, patients in ICU, you feel you are giving a lot of fluids. That fluid is just going out and they become edematous, then there are a lot of problems including respiratory dysfunction. So my suggestion would be not to give too much of fluid to patients who are in ICU. Which fluid to give? Now there is more or less consensus that in acute pancreatitis, renal lactate is better than saline. And similarly, in ICU, critical patients also, renal lactate is preferred over normal saline in most situations. Monitoring this fluid is very important. Our goals here are that we need to have a minimum mean arterial pressure about 70. We need a hematocrit of about 40 to 42. So in the beginning, you may find a patient has hematocrit for 45, between 45 and 50. That means they are really dehydrated. So one of the simplest tests that you can do in the beginning to assess the fluid status is to do hematocrit. Very easy. And if you find it is 47, 48, 50, give fluids rapidly and bring it down to about 40, 42. And of course, we want a urine output about 1 ml per minute. How do you monitor? So CVP in general is not a good guide to assess fluid status. Two things have emerged over the last 10, 15 years, which I think can be applied in any hospital setting. It doesn't require a sophisticated things. One is bedside ultrasound to measure the IVC and its variability. And second is lung ultrasound. Nowadays, most intensive units have a lung ultrasound. All the intensivists, anesthetists, radiologists are able to do it. In our unit, all our residents do it. It can show you B lines. If you see B lines, you know this patient has fluid overload and should decrease the intake. So the general recommendation now is give about 2.5 to 3 liters of fluid in 24 hours. This is only for the first few days. After that, your intake and output should match. So only in the first 48 to 72 hours, this applies. Now coming back to the patient developed fever on day 3, counts went up to 14,000, PaO2 FiO2 ratio was 280. You should be more than 400. That means now patient has respiratory dysfunction. Creatinine rose to 2.4. Bilirubin came down 1.8 to 1.1. SGPT came down to 142, 260. Now this means that the stone which came out of the gallbladder and obstructed the lower end of the bile duct at the ampulla, which caused pancreatitis, has passed out. So if you just follow liver function test, in the first 2 to 3 days, you will know, one, that this cause is likely to be gallstone, and two, the stone has passed out. You don't need to do ERCP. So if there is persistent stone obstruction and cholangitis, we have to do early ERCP, otherwise no. This patient doesn't require ERCP. So the concerns from now day 3, 4, 5, 6, 7 are, if this patient has organ failure, they need ICU care for sure. Many of these patients develop what we call as infected necrosis. Once you have necrosis and fluid collection, which I showed you CT pictures, they can get secondarily infected, called infected necrosis. This again contributes to morbidity and mortality. That's the concern. This occurs usually in the second week of illness, not in the first. And third, you have to maintain nutrition in these patients. Those patients who have severe acute pancreatitis like this are in ICU, mortality is very high. We published a paper on the pathophysiology. If you are interested in understanding the pathophysiology of organ failure, you may refer to this article published a few years back. Now, I want to point out to this audience some caveats about organ failure and acute pancreatitis. This is based on our recent experience of many patients. And the reason I want to emphasize is that the problem may be something else and we may attribute it to acute pancreatitis. So this young boy came in with abdominal pain, no fever here, decreased urine output, hypoxia, altered sensorium. He was ventilated, dialyzed, etiology workup, whatever he could within 1 or 2 days was negative, counts were very high, and platelet was falling, and the amylase lipase was high. So we didn't know what is happening here, but we managed in ICU with whatever support we could give, and what we found a day later that he had malaria, falciparum malaria. Diagnosed on simple peripheral smear. Unfortunately, we lost him within 48 hours. It was too late. Young female came in with symptomatic gallstones with abdominal pain, and we thought it is likely to be gallstone pancreatitis. She had decreased urine output, required hemodialysis. She developed hypoxia, ventilated, inhaled sensorium, and we managed to conservatively. And after 2 days, we wanted to place a nasogastric tube, nasojejunal tube for nutrition purposes. And what we found on upper GI endoscopy was a large, deep gastric ulcer, the biopsy from which showed fungal infection, mucormycosis. And despite our efforts, we lost her within 2 days. Third patient, young male, came in with abdominal pain, high-grade fever and jaundice, no decreased output, no short of breath, but later he developed hypoxia, anemia and thrombocytopenia. Ultrasound was bulky, there was some pancreatitis. His leptospira came positive, scrub typhus was positive, patient improved with IV antibiotics. So with these 3 cases, what I've shown you is that not all organ failure are because of acute pancreatitis. Very early organ failure in such patients could be because of the primary illness, which is also secondarily involving the pancreas, not the other way around. And these are eminently treatable patients. If you pick them early, then they can be treated well. So not because just there is some pancreatitis, you ascribe everything to that and not look further. That's important point. Coming to the management of patients, because patient had fever and raised counts, should I give antibiotics or no? So there is no role for prophylactic antibiotics. Fever and raised counts in the beginning of the illness are because of sterile inflammation. In fact, if you do give antibiotics, they develop more resistant infections later during the course of the illness, gram-positive infections and even fungal infections. The next concern is about nutrition, because in the first 2 days or 3 days we are giving IV fluids. How long do I need to give fluids and not feed this patient? So there has been a concept about when to start nutrition in mild or severe pancreatitis, does the timing affect, and how do I give this nutrition? So there are some guidelines available. So there was a concept of pancreas rest, that don't feed these patients, give rest to the pancreas, the fluid secretion will not be there and patient will be better. But this concept has now been given up. Oral feeding should be started in those with mild pancreatitis as soon as the abdominal pain starts increasing. So within the first 2-3 days, you should start feeding your patients. In those with likely severe disease, showing SIRS or early organ dysfunction, we should give enteral tube feeding if they don't tolerate oral feed. So enteral tube feeding is important in those with relatively severe. Either you can place a nasojejunal tube under fluoroscopy or endoscopic guidance, but both are quite similar. But most patients do not really tolerate nasogastric, and we end up placing nasojejunal feeding in nasojejunal tube in them for feeding purposes. There is no point giving any elemental or semi-elemental diet. These patients tolerate polymeric diet. The usual feed that you can give to any other patient is given. Our target calories is about 30 kilocalories per kg, which you can build over a few days. Not necessarily on day 1 you give that, because patient may not tolerate. and your target protein intake would be around 1 to 1.5 gram per kg body weight. And rarely we rely on TPN. TPN should not be given. Early enteral nutrition is important in these patients. Now, beyond the first week, second week onwards, these patients might develop secondary infection, as what I said, infected necrosis. If you have large collections like this, CT scan shows large collections here. These collections may get infected. If you see air within it, you know it is secondary infected. The treatment here is either percutaneous drainage, or like this, you can place under radiology guidance, and these patients may do well. Or if the collection is large and it is in the lesser sac, then nowadays the preferred treatment is EUS guided endoscopic drainage of this collection. And in some of these patients, we might actually do necrosectomy endoscopically. So you can see the large fluid collection here under fluoro and EUS guided. This is a kind of a metal stent which is placed inside. And once you place a metal stent, it has a diameter of about 16 millimeter. And with a 16 millimeter diameter stent, it actually opposes both the walls, and a lot of fluid will come out. And also, this is enough to do necrosectomy with the help of an endoscope. You can see here a lot of fluid coming out after the drainage. And in some of these patients, you could do necrosectomy as well. Now, a word about special situations, because some of you might see pediatric patients and you may see pregnant patients with acute pancreatitis. So common causes in children are either genetic mutation, viral infections, gallstone. In fact, in somewhat older children, you may see gallstone as the cause, and drugs. Particularly, for example, L-asparaginase in those with ALL. This is one of the commonest drugs. In fact, this is something which can cause moderate to severe pancreatitis. Severity in general in pediatric population is mild. Management is similar to that in adults. There isn't much difference. But fluids and analgesics should be given weight-based, and of course, the pediatrician know it very well. Recovery is much better than in adults because children have a better capacity to handle inflammation and recover faster. Acute pancreatitis in pregnancy is uncommon, but we do see patients coming with pancreatitis. The most common or the usual cause is gallbladder stones, because pregnancy is a state where they are susceptible to develop gallbladder stones, and that is the reason why we should differentiate acute pancreatitis from acute biliary colic. So they may come with biliary colic, which is more common. They come with acute cholecystitis, which is more common. But sometimes they may have acute pancreatitis as well. The problem here is a high risk of preterm birth and fetal loss, which could be as high as 15 to 20%. But management overall remains the same. One particular point is that you should refer these patients to a surgeon for cholecystectomy during pregnancy. And the best time would be late second trimester, early third trimester, because if you don't do cholecystectomy, they have a high chance of recurrence of biliary and pancreatic complications, and cholecystectomy has been shown to be very safe during pregnancy. So this is one message I want to give to the gynecologists who are here and the surgeons, that there is no problem doing cholecystectomy. It is the recommendation by various society guidelines to do cholecystectomy during pregnancy itself. So the learning points in the first 2 to 3 weeks would be that first few days are critical. If there is SIRS or organ failure, you should refer this patient to a higher center. Give adequate and optimum hydration to these patients. Serum amylase, no monitoring is required, and you don't need to do early or repeated CT scans. And in the beginning, don't put a nasogastric tube for aspiration. That is not required. We need to give adequate analgesics, particularly opioids. Early enteral nutrition is very important. This has been shown to decrease morbidity and mortality in these patients. There is no role for prophylactic antibiotics. ICU care is required for those with organ failure. And if a patient is unwell, develops new onset fever, we know the patient is now developing infected necrosis, and this patient would require interventions, and that's the reason we should refer to a higher center. I'll spend couple of minutes on the follow-up of these patients. And the reason I want to spend a couple of minutes on that is that often patient gets better, the patient is discharged home, and then we forget about it. And then they come back with a problem. So the things that you should remember about these patients is development of diabetes, malnutrition, how do you prevent recurrence of pancreatitis, and should you look for development of chronic pancreatitis. So diabetes may develop in even young patients. Up to 30% of those may develop diabetes after recovery from acute pancreatitis, and this could be very problematic to treat. The risk factors for diabetes are pancreatic necrosis, more extensive necrosis, like more chances of developing diabetes, necrosectomy, those who undergo necrosectomy, alcohol etiology, and higher age. And that is the reason why periodic monitoring of blood sugar is essential in these patients. Please do follow your patients and advise them blood sugar monitoring. Malnutrition in those with moderate to severe pancreatitis is very common. They lose 10, 20, 30 kgs of weight during hospitalization. And those of you who are gastroenterology surgeons treating patients with acute pancreatitis know that very well. And it is a risk factor for premature death. In fact, now a couple of studies recently have shown higher risk of death even after discharge, and this is one of the important problems there. And these patients require nutritious diet and an exercise schedule to bring their muscles back to shape. Now, prevention of recurrence of pancreatitis, again, very important, and two things you should do. One, cholecystectomy in those with mild pancreatitis within the same admission. Within 7 to 10 days, the patient should undergo cholecystectomy. There is no problem, and surgeons know it very well, that it is safe to do cholecystectomy. But in those with severe or moderately severe pancreatitis, you should wait for about 6 to 8 weeks so that their local complications are treated. And then patients should undergo cholecystectomy. Another thing we often forget is de-addiction in those with alcohol and smoking. And we think that, just telling patients they will stop smoking or taking alcohol, that's not true. You must take professional help and advise them about abstinence. The last problem which many of these patients might develop is from acute pancreatitis, they might develop recurrent acute pancreatitis, and then finally, some of them may develop chronic pancreatitis. About a quarter of these patients develop recurrent acute following recovery from acute pancreatitis, and about 10 to 20% of these patients will develop chronic pancreatitis. And in a study we did many years ago, we found that about half of patients who have recurrent acute pancreatitis develop chronic pancreatitis over a period of about 10 years. So we recently wrote an editorial, and this is very important, that acute necrotizing pancreatitis may actually become a chronic disease. Now, acute means acute onset of disease, not a short course of the disease. And the reason I'm emphasizing this point is that we must follow these patients up for various complications and development of recurrent or chronic pancreatitis. So, ladies and gentlemen, I'd like to summarize by saying that acute pancreatitis is a common problem. I'm sure most of you must have seen it or will see it. Most cases, fortunately, have mild disease, and you should refer patients who have severe pancreatitis or those with infected necrosis. Follow-up is essential for cholecystectomy and alcohol abstinence and prevention of pancreatitis. And we must monitor these patients for development of complications, particularly diabetes. Thank you very much for your kind attention.
Thank you, Professor Garg, for such a wonderful and lucid talk. It was really wonderful. And I think all of us must have benefited from his talk. It must have enhanced our knowledge to manage these patients henceforward. I'm sorry to say, Raghukul Reet Sada Chali Aayi, in the context ki oration is not followed or supposed to be there any question answers. So I'm sorry for that. But I think we can talk to Dr. Garg personally. Thank you, Doctor. A big round of applause for him.
Thank you very much. And then just to say that the coach.
I would request our President and Secretary and Organizing Secretary to felicitate our Speaker and Chairperson. I would also invite Mrs. Poonima. Please join us on the stage. Mrs. Vasudha and Mr. Prateek, family of Dr. Anup, to please join us on the stage.
I request Dr. Neeraj Tripathi sir and Dr. Geeta Tripathi ma'am, please join us also. Neeraj Tripathi sir, Geeta Tripathi ma'am.
ये नहीं था ग्रुप पॉलिटिक्स अभी आएगा। बढ़िया अवार्ड वाली फोटो थी। ठीक है यार।